Welcome to this deep dive. Today, we're tackling rhabdomyolysis based on these really detailed revision notes you shared.
That's right.
Our mission, basically, is to cut through them, pull out the really critical high-yield stuff, and, make it stick for your revision.
Like a good revision shortcut.
Exactly. And I've got our expert here to guide us through it. And remember, this is for you. We're sort of working through these notes together. So first off, why is rhabdomyolysis such a big deal? Why is it so important to get our heads around?
Well, fundamentally, it's serious because it involves significant damage to skeletal muscle tissue.
Okay.
And when that muscle breaks down on a large scale, it releases all sorts of stuff into the bloodstream that really shouldn't be there in those amounts.
Right. And that causes problems downstream.
The biggest one, often, is acute kidney injury, AKI. That's a major consequence.
So the muscle goo, for want of a better word, just overwhelms the kidneys. Is that the basic idea?
That's pretty much it, yeah. The kidneys are designed to filter waste, but the sheer load of substances coming from these ruptured muscle cells is just too much.
Is cell membranes break down?
Exactly. They rupture and the contents spill out. It's characteristic, this overwhelming of the kidneys by muscle breakdown products.
Okay. The notes give a definition, mention the breakdown, the AKI link. They also list some broad causes right at the start. What are those main categories?
Yeah, they group them nicely. Things like trauma, significant muscle compression, drug toxicity is a big one, certain genetic conditions, and metabolic problems too.
In common situations.
They flag things like patients who've had falls, maybe lay undiscovered for a while, or people who've had seizures. The situations with, prolonged muscle pressure or really intense activity.
And the notes make it clear the stakes are high, prompt treatment is crucial. They even mention preventing cardiac arrest.
Absolutely key. It's not just about the kidneys, though that's serious enough. When muscle cells break open, they release electrolytes, particularly potassium. And if potassium levels shoot up too high, that's hyperkalemia, it can trigger really dangerous heart rhythms, potentially fatal ones.
So cardiac arrest is a real risk.
It is. So acting fast isn't just kidney protection, it's potentially life-saving from a cardiac perspective too.
Right. Okay, let's dig into those triggers a bit more. The etiology section in the notes, the causes and risk factors. It's quite a list. How can we make sense of all that for revision?
It helps to group them, like the notes do.
Okay.
So first, think direct muscle injury. That's your severe trauma, crush injuries, bad burns.
Compartment syndrome.
Physical damage. Exactly. Then there's muscle compression. That can happen from being immobilized for a long time.
Like the falls you mentioned.
Yeah, or someone unconscious after a collapse, or even just very long surgery sometimes. Pressure on the muscles.
Okay, makes sense.
Then drugs and toxins.
Yeah.
Huge category. Statins often come up, especially the interaction with drugs like clarithromycin. That's specifically noted.
Right, I saw that.
But also illicit drugs, cocaine, ecstasy, alcohol abuse, even some antibiotics or anesthetics.
Wow, lots there.
And then you've got conditions that mess with the body systems, like heat stroke, severe infections, flu, strep infections are mentioned, metabolic issues like DKA or thyroid problems, tumour lysis syndrome, even snake bites.
Okay.
And finally, don't forget the genetic side. Inherited muscle disorders like McArdle syndrome or problems with how muscles process fats or sugars.
So maybe for revision, we could think physical force, something taken, drugs, toxins, something internal going wrong, metabolism infection, or something inherited.
That's a great way to cluster it, yeah. It simplifies that long list.
Does that help with remembering the risk factors, too?
It does, because the risk factor section kind of echoes those categories. It mentions existing trauma, obviously, but also things like extreme physical exertion.
Like marathon runners.
Potentially, yes, or military training. Prolonged immobility, again, substance abuse, being on statins, having underlying muscle disorders, or conditions causing metabolic issues. The notes also mention age, specifically over 60, and African-American race as risk factors.
So grouping the causes, then thinking about who's already vulnerable, that makes the etiology section feel much less daunting.
Definitely.
Okay, let's get into the mechanism, the pathophysiology. How does this muscle damage actually cause all these issues? What's the how?
Right. It starts at the muscle cell membrane, the sarcolemma. The initial trigger, whatever it is, damages this membrane. That breach is the critical first step.
Because things leak out.
Precisely. The cell contents spill into the surrounding tissue and then get absorbed into the bloodstream.
And what kind of stuff leaks out?
You get enzymes like creatine kinase, CK, that's a key one, electrolytes, especially potassium and phosphate, and critically, a protein called myoglobin.
Myoglobin. And that's the main villain for the kidneys, right?
It really is. Myoglobin normally carries oxygen inside muscle cells, but when it floods the bloodstream in high amounts, it's directly toxic to the cells lining the kidney tubules.
Has
It can clump together and form casts inside the tubules, physically blocking them. This directly damages the tubules, causing acute tubular necrosis, ATN, and leads straight to AKI.
Ouch.
And there's another mechanism the notes mention. The membrane damage also allows too much calcium into the muscle cell.
That sounds bad.
It is. This excess calcium activates enzymes inside the cell that basically start breaking down proteins and membranes further. It triggers this kind of self-destruct process.
This vicious cycle.
Exactly. Damage leads to calcium influx, which leads to more damage and more leakage.
So it perpetuates itself. And the myoglobin leaking out, that causes the dark urine sign.
That's right. That classic, although not always present, dark reddish-brown or tea-colored urine. That's myoglobinuria. It's the muscle pigment staining the urine.
Not actual blood, then.
Usually not, though a dipstick might test positive for blood because it reacts to the heme part of myoglobin, similar to hemoglobin. But microscopy often shows few red blood cells. The notes point out that confusion is possible. And two things make the kidney injury worse, according to the notes. An acidic environment in the urine makes myoglobin more likely to form those damaging casts, and dehydration, or hypovolemia, reduces kidney blood flow, making them more vulnerable.
Understanding that whole cascade damage, leakage, myoglobin blocking kidneys, the calcium thing making it worse, really clarifies why you see the signs and symptoms, makes it easier to remember.
Absolutely.
Okay, let's shift slightly. If you see a patient, maybe muscle pain, feeling generally unwell, what else could be going on? What are the key differential diagnoses mentioned?
That's vital, yeah. You need to think broadly. If AKI is present, you have to consider other causes of kidney failure. Things like ATN from other causes, toxins, low blood flow, or different types of kidney inflammation like glomerulonephritis, or even just a simple blockage in the urinary tract.
Okay, so other kidney-specific things.
Right. And if the main picture is muscle pain and high muscle enzymes, you need to differentiate rhabdo from other muscle conditions. The notes specifically mention things like polymyositis or dermatomyositis. Those are inflammatory muscle diseases.
Right.
And also inherited conditions, the muscular dystrophies, the clinical context, the exact pattern of lab results, the patient's history. That's all crucial for telling these apart.
So sorting out, is it kidney, muscle, or both, and why? Good point for revision practice. Questions, differentiating those.
Definitely high yield.
What about frequency? How common is rhabdo? Who gets it?
The notes give U.S. figures, mentioning around 25,000 cases a year there. And importantly, somewhere between 5 and 30% of those people develop AKI.
That's quite a range.
It is. And it can affect anyone, really, but certain groups pop up more often: athletes pushing limits, military personnel, people with substance abuse issues. The notes re-mention those specific risk factors: African-American race, obesity, being over 60.
And trauma situations?
Yes, tragically common in mass casualty events like earthquakes or wartime situations because of crush injuries. It's a major component of crush syndrome.
Grim reminder.
And the notes do add a little caveat that UK data might vary from the US figures. Good to keep local context in mind.
It really highlights the diverse triggers, doesn't it? From elite athletes to someone trapped after a fall.
It does.
Okay, back to the patient. What does someone with rhabdomyolysis actually look like? What are the key clinical features to spot?
Well, there's the classic triad, though you won't always see all three together. Muscle pain, muscle weakness, and often swelling in the affected muscles.
Okay.
And as we discussed, that dark, tea-colored urine is a very suggestive sign if it's present. Patients might also just feel generally rough fatigue, nausea, vomiting.
And signs of kidney problems.
Yes, if AKI is developing, you might see reduced urine output, maybe some fluid retention like swollen ankles. In really severe cases, you might see complications early on, like signs of compartment syndrome in a limb or effects of the electrolyte shifts.
Any less obvious signs?
The notes mention non-specific symptoms too, especially maybe in older patients or those with trauma. Things like confusion, fever, just feeling generally unwell, malaise, loss of appetite, without necessarily complaining of specific muscle pain. So you need a high index of suspicion sometimes.
Right, so don't just rely on the classic triad. It might present more subtly.
Exactly. But for revision, the lab findings are absolutely crucial. This is probably the highest yield bit for diagnosis and checking severity. The absolute hallmark is a massively elevated creatine kinase CK level.
How high?
Often thousands, tens of thousands, even higher. way, way above normal range. That's your #1 diagnostic clue.
The CK.
Then you look for the AKI markers on the renal function tests, rising creatinine and urea, and electrolytes are critical. The notes stress looking for low calcium, hypocalcemia, high phosphate, hyperphosphatemia, and especially high potassium, hyperkalemia.
The dangerous one.
The most immediately dangerous one, yes, because of the heart risk. And metabolic acidosis is common too.
Yeah.
The damaged tissue and failing kidneys.
Okay, so if I remember one lab, it's CK sky high, then immediately check electrolytes, especially K+ and kidney function. Those are the must-dos.
Absolutely essential.
So how do we actually confirm it? What are the key investigations?
Well, as the notes say, it's mostly the clinical picture plus those key labs. Serum CK is #1. That level confirms muscle damage and gives an idea of severity.
Okay.
Urine analysis is vital, looking for that dark color, checking for myoglobin. Remember, the dipstick often positive for blood, but few red cells on microscopy that suggest myoglobinuria.
Right.
Then obviously renal function tests urea, creatinine to see how the kidneys are doing. And a full electrolyte panel is non-negotiable. Potassium, calcium, phosphate.
Any role for imaging?
Sometimes.
Yeah.
Ultrasound or MRI might be used to look at the extent of muscle injury, or if you suspect something like compartment syndrome.
Yeah.
And for recurrent cases, or if you're thinking genetics, the notes mention things like muscle biopsy or genetic testing might be considered later to find an underlying cause.
So CK first and foremost, backed up by urine, kidney function, and electrolytes. Core tests.
Exactly. Simple but high impact.
Right, management. Given the risks, I assume treatment needs to be quick.
It's extremely quick. Critical. The goals, as the notes lay out, are stop more muscle damage, fix the fluid and electrolyte chaos, support the kidneys, and, crucially, treat whatever caused it in the first place.
And what's the first step?
Fluids. Aggressive intravenous fluid rehydration. That is the absolute cornerstone. You need to push fluids early and hard.
Why exactly?
It does several things. It dilutes the myoglobin in the blood and tubules, helps flush it out, improves blood flow to the kidneys, all reducing the risk and severity of AKI. The notes really hammer home how vital early aggressive fluids are.
Okay, fluids first. What next?
Manage that high potassium, the hyperkalemia. It's an emergency. The notes mention standard treatments. Calcium gluconate to protect the heart, things like insulin with dextrose or salbutamol to shift potassium back into the cells.
Got it. Any other treatments?
Well, diuretics are mentioned as controversial, maybe marginal benefit. Alkaline diuresis using sodium bicarbonate to make the urine less acidic is another strategy sometimes used. The idea is to make myoglobin less toxic in the tubules, again, trying to prevent AKI.
And if the kidneys fail anyway?
If severe AKI, acute tubular necrosis, sets in despite everything, then hemodialysis might be needed temporarily to do the kidney's job. And you absolutely must treat the underlying cause, stop the offending drug, treat the infection, manage the seizures, whatever it was.
Makes sense. What about statins? There was a specific note.
Yes, if someone on a statin develops rhabdo, you need to monitor them closely and usually stop the statin, at least temporarily, or consider adjusting the dose. The notes remind us of the risk factors for statin muscle issues too, being older, drug interactions like with that clarithromycin, having hypothyroidism.
Okay, so the mantra is fluids, 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 then fix potassium, treat the cause, simple priorities.
That's the core of it.
And what's the outcome usually? What does the prognosis section say?
It really depends on how severe the muscle damage was initially, what caused it, and critically, how quickly it was managed.
So timely treatment matters hugely for outcome.
Massively. The good news, the notes say, is that with prompt, appropriate treatment, most people actually recover fully without long-term kidney problems or other issues.
That's encouraging.
But severe cases, or if treatment gets delayed, that's when you run into trouble. Potential for long-term kidney damage, chronic kidney disease, even multi-organ failure. Mortality is rare, but it can happen.
So that emphasis on early fluids and management really pays off in terms of prognosis.
Directly links to better outcomes, yes.
Okay, finally, let's just list those potential complications the notes highlight. What can go wrong?
A lot of it follows directly from the pathophysiology we talked about. #1 is acute kidney injury, AKI, from the myoglobin blocking the tubules.
Right.
Then the dangerous electrolyte imbalances, especially the hyperkalemia causing arrhythmias and hypocalcemia. High phosphate is also noted. If the muscle swelling is really bad, you get compartment syndrome in a limb, which needs urgent surgery, a fasciotomy, to relieve pressure. Yeah. DIC, disseminated intravascular coagulation, that's a serious clotting and bleeding disorder. It's another potential complication. Long-term, there's a risk of chronic kidney disease. The notes also mention possible liver enzyme rises, like AST, metabolic acidosis, and fluid just pooling in those damaged muscles, plus any complications from the original trigger.
Okay.
And the notes really underline that the combination of hyperkalemia, metabolic acidosis, and AKI is strongly linked to worse outcomes, higher morbidity and mortality.
Yeah.
It just reinforces again why spotting it early and intervening fast is so crucial.
It really is like a domino effect, isn't it? Muscle damage, leak, and systemic problems. Remembering that flow makes the complications seem less like a list and more like logical consequences.
Exactly.
Well, that was quite a journey through those rhabdomyolysis notes. We've covered the definition, the huge range of causes, the pathophysiology, which is quite complex but key, the vital lab findings, the urgent management steps, and the potential complications. I think breaking it down like this really helps make it more manageable for revision.
Definitely highlights the critical bits.
What really stands out, looking back at the notes, is just how common some triggers are. A fall, a seizure, even certain medication combos.
Yeah.
It makes you think, doesn't it? How often might milder cases be missed? Maybe the symptoms are vague, especially in an older person who's fallen. Perhaps they don't have classic muscle pain. Is our clinical suspicion always high enough outside of obvious trauma?
That's a really interesting point. How much awareness do we need in more routine assessments? It's definitely food for thought.
A challenging thought to end on. Hopefully this deep dive has boosted your confidence in understanding rhabdomyolysis for your revision and practice.
Hope so.
And remember, for more revision support, practice questions, and resources, do check out pastthemsra.com and freemsra.com.
Great resources there.
Thanks so much for joining us for this deep dive.